Have a scotch, Glenn.
You'll have to drive home. Talk to you
Oh,
later.
sorry. Okay.
Bye-bye.
Bye-bye.
Great. Are we ready to get started, Patty?
Good, CJ, ready to go?
Yes.
All right. Let's go.
Great. All right. Welcome, everyone. I am Amy Hewitt, Executive Director for the National Kidney Foundation, serving Northern California, Oregon, and Washington. We have a fantastic program for our first Journal Club of 2022. So thank you all so much for joining us. Before we get started tonight, I really, we'd like to acknowledge the many people who make our work and these programs possible. Our program chair, CJ, speakers, sponsors, exhibitors, and of course you, our attendees. You make all this possible. 2022 has certainly gotten off to a difficult start for many, but we know that it has been especially challenging for healthcare professionals. Over the last 2 years, you've carried so much of the weight, and through it all, you have cared for our kidney community with compassion, skill, and perseverance. Thank you is not nearly enough, but please know how deeply grateful we are for all that you do for our community. So just a few things before we get started with for today's session. We'll be using the Zoom's chat feature, which can be found at the bottom of your screen. We know after 2 years of virtual programming, I'm sure you're all familiar with it, but we thought we would just warm up with a quick chat box. And so please make sure when you're using the chat that you're using all panelists and attendees is checked off in the chat box. And then I will ask you to answer this question. Where are you joining us from, and what was the last thing you ate or drank? So you can just type that in. Maybe it's Scotch for Dr. Chertow. Or not. Gig Harbor, Washington, some red wine. Love it, Laura. Good job. I know we've got somebody from Chicago, so feel free, just make sure to please use the Portland, another red wine. Burlingame and cheese, I like that too. All right, so this is a very open group, so we use the chat to pose questions to the speakers as they're going through their talk. We also open up the dialogue to voice questions, and CJ is really, Dr. Zhang is really great about building those for our speakers. So I will, San Rafael and Pad Thai, yum. All right, so I will turn it over to my colleague, our Senior Program Director, Patty McCormick.
Yeah, of course it skips. Thank you, Amy. A lot of comfort food going on out there. Wouldn't mind some of that myself. I want to take a minute to thank our presenting sponsor, Bayer. We are eager to learn more about how their work is impacting the care of patients with type 2 diabetes as it relates to end-stage kidney disease. Thank you again for your generous support. Thank you also to our exhibitors Amgen and Sanofi Genzyme. For both Bayer and our exhibitors, see the chat box for their contact information, and please reach out to them for answers to any questions you have and to learn more about their good work. NKF's research grant program is now open for submissions. I want to highlight this one, the newest Health Equity Community Engagement Award. We will include this link in the chat and in the follow-up email so you can learn more about this and other grant opportunities. And before I introduce our moderator, I want to share our upcoming programs. The link to register for these will be in the chat and in the follow-up email. We have a real roundtable on Thursday, February 24th on the treatment of secondary hyperparathyroidism. Our next Journal Club is on Thursday, March 24th, and Dr. Zhang has put together another great program with expert speakers you won't want to miss. And spring clinicals are coming up in April, happening in Boston in person this year, April 6th to the 10th. And please save the date for this year's 54th Annual Medical Symposium. It's now my pleasure to introduce our program chair, Dr. CJ Zhang. Dr. Zhang has long led our Journal Club efforts in the East Bay when in person and virtually throughout the pandemic. His vision and energy has been unwavering throughout. His spirit of innovation and adventure allowed us to move to the virtual world with relative ease with both the Journal Club and our annual medical symposium. Dr. Zhang is entering his 4th year as chair of that program as well. We are very, very grateful to you, CJ. Please take it away.
Thank you, Patty and Amy. I'm very grateful to you also and NKF. This Journal Club started in 2014, initially at local in East Bay. In Bay Area, we gathered together to share cases in 2020, when pandemic hit, we moved to virtual and we expand our audience and speakers. And tonight we have 3 excellent speakers. Our first speaker is Dr. Andrew Sedlicki from Harvard. He's a assistant professor at Brigham and Women. Andrew and I are co-fellow together at Washington University of St. Louis, and he stayed for another year as a transplant fellow. Then he moved up all the way to Harvard, and he's going to talk to us about 3D printing of AV fistula. Thank you, Andrew.
Thanks for the invitation, CJ. Really
welcome.
appreciate it. It's great to see such a broad audience here also. I'm going to try to share screens here and get started. So what I'll try to convey in the next short while is really a method and then a little bit of its application. The title of the talk here is Precision Care and ESKD, 3D printing of tailor-made AV fistulas and grafts for the individual patient. So disclosures first here. So one of the contrast agents that we use for this, we've negotiated a grant between the hospital and that producer, ANAG Pharmaceuticals. What I'll be describing is detailed in further description when it comes to the method of the 3D print and how to go about doing that in this article, but we'll try to make it a little bit more clinically applicable. And you know, the idea here is that when it comes to dialysis, the people that are directly interacting with our patients on nearly a daily basis and really are the caretakers of those patients' dialysis accesses are the technicians who sometimes have limited experience. There are certainly others that are in the dialysis units that have been taking care of patients for years, if not decades. Others with limited experience, and you know, sometimes the dialysis technician is compared to a hairdresser, where the dialysis patient will only select particular technicians to cannulate them, which can become an issue. So the idea here is to approach a real practical problem with a tangible answer, and that is tailor-made dialysis accesses to benefit those technicians that are cannulating our patients. But limitations really, it does involve also very practical things that you know, can limit the number of patients that are able to actually have a model generated. And so if those providers that are taking care of the patients feel that there is no radiologic contrast that can be given for that individual patient, then it's difficult to actually the necessary imaging data. And secondly, if that contrast of request is not available at your hospital facility, then that also becomes an issue. But for those that it is available, this is the sequence, or at least conceptually, what we're trying to do is acquire images that really can be generated either by CAT scan or MRI in the current day. But generally speaking, it needs to be tomographic imaging, so you have slices that you can then reconstruct. I think my colleague, Dr. Yi Li, is on the video conference also, and he really has been instrumental in steps 2 and 3 here when it comes to receiving the data. So the radiologist is really critical here when it comes to getting us good images that reflect what we need to see inside of the post-processing phases of the model generation. But then Dr. Li, for instance, is just a real whiz when it comes to transferring those files that you receive in any radiology department, DICOMs, and then moving that into a software format that can then be readable by the 3D printing apparatus. Once the data is cleaned up a little bit to actually look like the access or the original images that the radiologist gave to us, then we print and present it to the patient. So this first patient that I'll share with you here, he really was the pilot case. And it was a very cooperative patient. We ended up using ferromoxetol, IV iron agent, which is used for treatment of, or FDA approved for treatment of anemia of chronic kidney disease, but it also just is an excellent contrast agent as well. So a little bit of anatomy here. These are images that were generated from an MRA, magnetic resonance angiogram. And you can see the large vessel here marked as a C. If you kind of squint there, that's a C. That's the cephalic vein. And he had what so many of our patients have, that outflow stenosis. And so one of the local surgeons created a cephalic vein bypass. And so that bypass actually connected with the axillary. And we'll go through this anatomy a little bit more, and with repetition, I think you'll be able to conceptualize what you're seeing in just 2 dimensions here. So the radiologists that we're working with at the Brigham and Women's Hospital, again, just real cooperative. It's been a very collaborative effort. And here again, the brachial artery, very, very narrow, close to the armpit. This is the patient side here. Cephalic vein, again, cutaneous and towards the outward portion of the patient's upper arm. Should I clarify? This is not inside of the wrist. This is the upper arm. And then your cephalic. So I'm going to try to move the Zoom screen out of the way. So again, just kind of let your mind wrap itself around that image. Is just the same imaging that we're looking at as a radiologist would be able to do inside of their imaging software, but what we'll try to do inside of a 3D print format. So again, we have the images. Just recognize that these are great images. They are DICOMs, where the cursor is located now in the color. We move them to an STL file format, which again is kind of noisy, but Dr. Lee and others of his expertise, which we found out at Boston College, there's actually a number of undergraduates that are pretty proficient at this SAFOR platform, and so we're trying to get them involved also. But once it's cleaned up, this is again what the model looks like, and the idea is that it looks very similar to the DICOMs that were generated in the first place, and that's the purpose here, is really to be true to form. When it comes to creating these models, we want specificity such that these technicians really don't have to guess as to where they're going or what they're seeing. So I'll just pause this here. Try to. What I want to highlight here, and you'll see this again and again, is when you're holding on to these models, and I've asked the technicians to hold on to them and really just try to, I'm going to try to go back here, try to guess first as to where, I'll try to pause it here, where the anatomy is located, because they're really great at that. All right, we'll just skip to the next slide here. But the idea is that, again, this brachial artery is very small, and it's always wavy. So you have an endless number of variations when it comes to an upper arm access, simply using an anastomosis between the brachial artery and the cephalic vein. But the way that those actually present and they look inside of an individual patient, how deep these vessels are, how cutaneous they are, again, endless variation. And so it's important to kind of understand landmarks or what you're going to see in the model and then go from there. So what I want to show you inside of this sequence of figures is that what Dr. Lee has been able to do is adjust this software so that you can either generate a solid model or you can generate a hollow model. And the idea that has to be reinforced is that the images that we're getting are intraluminal. So it's always contrast inside of the vein. Now compare the hollow version here on the right-hand side in the inner diameter to the solid version here in the diameter of the vessel. This is just software. This is not anatomically correct in the sense that it would almost appear that there's a stenosis here, and there isn't. It's simply the software, at least in the form that we're using, only able to build inward when it comes to generating an intimal thickness. So what we're in the process of doing is trying to get the software to build outward, with the idea that technicians are using every component of their body to try to find, or all of their senses to try to find that intraluminal space for the access, feeling for a difference or a release of resistance. So to be able to identify that the intimal thickness of the cephalic vein is 3 millimeters, they will be able to feel that, and they will be able to know what 3 millimeters feels like if we can do so accurately. Currently, the easiest model to print is the solid model, but there are expanded options that again we're trying to make available to the print. So this is the machine that we're using, but believe it or not, this machine was collecting dust in the basement of the Brigham and Women's Hospital, and we discovered it after the last scientist had left for greener pastures, I think in UCSF. And if you can see, just again squinting, in the background here is some of the printed models that this scientist had left behind. They worked with the cardiovascular team a lot when it comes to generating coronary artery trees. And so this is a discovery of happenstance, really, when it comes to the machine that was available. It's very old in the sense that it uses a liquid resin. The means of generating 3D models now are more powder-based, and so it's more efficient, and it doesn't require the resin to dry. But we used what we had, and it actually turned out quite well. So once we have the DICOMs, convert those to an STL file, we then can generate the model, and this is what that patient's access looks like in a solid resin form. Again, the wavy brachial artery, the cephalic vein bypass, the cephalic vein, the anastomosis between the brachial artery and the cephalic vein, the cephalic vein distal stenosis, and then the anastomosis between the cephalic vein and the axillary vein. This is actually a grafting material, so cephalic vein bypass and the axillary vein. Labeled again, just to, again, orient yourself. A lot of this, again, what we're trying to emphasize to the technician is to, in their mind's eye, visualize what this model represents, and then apply that over top of the access, which they can palpate and which they can at least see in a limited form cutaneously. Just to finish up on this first patient, probably the greatest point of emphasis here in the uniqueness of this access is the proximity between the brachial artery and the axillary vein. So again, seen here, really difficult to identify simply by the 2 dimensions. But realize that if you're a technician and you're being instructed to palpate and to auscultate in order to find areas where there's a thrill and a bruit, there's certainly an area that is cutaneous, which has those characteristics. But boy, what happens if you're not able to cannulate successfully the first time, and you hear and you feel a thrill and you hear a bruit in the more proximal component? Maybe I should cannulate there. Well, if you miss inside the cephalic vein, you'll cause trauma, probably a hematoma and some pain, but you aren't going to cause a vascular emergency. Where if a technician cannulates improperly, passes through and through to the axillary vein, and then tears the brachial artery, that can be life-threatening. And so I think these components of the anatomy really do need to be emphasized, and how much trust we're putting inside of these technicians when they're cannulating our patients. All right. So what we've also been thinking of doing is when we give these accesses to dialysis units, to provide some kind of supplemental video, just to emphasize where these accesses are supposed to be placed, how they're oriented. Believe it or not, we provided an access to one of the dialysis units, and again, just gave it to them and asked them to try to orient the model as they thought it would be most appropriate, and it was turned upside down. It's really, I think, just some obvious guidance early in this project that's necessary to really get people kind of off the ground and running with these models. So second patient, second clinical scenario, this is to emphasize depth, and more so inside of our patients that are sarcopenic, those patients that have a thin build. This patient actually, there was difficulty in cannulating her access, which you can see here somewhat just by the cannulation sites and the somewhat the change in color as well. And certainly when you palpate this, you know that it's a cephalic vein that's being used for the access, the AV fistula. But she was actually being cannulated too deeply. And I think that was because the people, the technicians inside of that particular dialysis unit, there's a number of morbidly obese patients. And so to change body size and try to use that same technique becomes quite difficult. Recognize a little difference in the model that's generated here. This is actually from a CAT scan. So we inquired with patients that were anuric as to how to go about obtaining these same kinds of models. And so we've actually been generating models using iodinated contrast in patients that are anuric and still dialyzing afterward. I mean, realize they're receiving over 5 grams of iodine during a contrasted imaging study. So again, supplemental iodine, at least inside of the daily diet, is somewhere on the average order of 150 micrograms. So I don't think it's a good idea to have that amount of iodine in your system. At the same time, to be able to have dialysis immediately afterward, I think again it's simply a safety measure that's worthwhile. But what I want to emphasize here is that with the CAT scan, we have bony structures that are available. And now we really have a strong bone structure, which these are not anatomic. These are struts that Yi added. But it does emphasize the depth and how far away that patient's access is to their actual, to the humerus. And in this case, you can nearly wrap your hand around the patient's bicep. I mean, she's just not a large person. And so it again emphasizes anatomy and how deep or superficial patient's access is. I realize that we're coming up close to the time here. So On the far right side, again, the idea here, it's an overlay. If you can see the patient's arm, it's just an overlay of the access anatomically proportioned to their arm. And so the idea is that this is what the technician is trying to do, is in their mind, can they see that model and then use that to guide them with the physical exam and techniques that they're conventionally used to. All right, so trick question here. How many access sites does this patient have? And I'm joking a little bit, but at the same time, count them. There's 4 cannula needles here. 2 of them have blood inside of them. There's 1 cannula needle with blood. There's a second cannula needle. This is the arterial stick, and this is the venous stick, if you can believe it. And here are 2 cannula needles that have no blood inside of them because they weren't able to successfully cannulate that patient. And there's a model now available for this patient. She has a complicated anatomy. The technicians oftentimes don't know what the anatomy is. They're not given it to them in advance. But in this case, this patient has had an access for 10 years. And so the work that was originally done was done 7 years prior. And so some of these records are not even available if you went looking for them. So this is what you find underneath the surface. So again, trying to find similar components to a model, which again is unique for each patient. But here it is. We've removed the more distal portion of the brachial artery, but here is the anastomosis between the brachial artery and the cephalic vein. Here is that somewhat wavy brachial artery here. This is actually a portion of the axillary vein, but for model purposes, we're trying to simplify the model as well. So it gets a little confusing up here, but again, this is the wavy brachial artery. This is a basilic vein transposition. So this patient's basilic vein was actually superficialized and then brought across the patient's arm in order to, again, make the basilic vein more superficial. And so note where the blood is inside of these cannula needles. It's up here inside of this basilic vein, as compared to the cannulation techniques which were previously attempted, which were down here inside of a typical location in the cephalic vein, which is actually very diminished in size. And the technician said, well, if you try to cannulate up here, you actually hear a crunching sound. Well, there's a stent that's placed in this component of the cephalic vein, and no wonder they're experiencing a crunching sensation. So again, just kind of real world demonstration of how this model has been able to now provide a patient with a successful access that can be cannulated. And this patient, again, mind's eye view here, is one of those that does not have a dialysis center because of non-compliance. And the concern is that she's as frustrated with cannulation of her access, or was as frustrated with cannulation of her access as the technicians were. So she didn't want to come to dialysis out of anxiety before other things. And since that model has been put in place, she's come to 4 consecutive dialysis sessions. It's not many, but when you talk to the technicians that see her in the emergency department on a regular basis, that's more consecutive dialysis sessions that she's had in the last 6 months. So we don't have outcomes data yet for this technique, but we are receiving positive responses from the technicians thus far. We do have a phase 1 FDA approved clinical trial, which we're trying to get off the ground. And hopefully the next time I talk with you all, maybe I can tell you a little bit about outcomes.
Great. Thank you so much, Andrew.
Absolutely.
Anybody have any question? Wonderful work. Thank you. Could 3D printing model be used to teach patients self-cannulation from home dialysis? That's my question too.
I think there's a lot of opportunity here, and what we've noticed early on when we give these models to people that don't have a lot of formal training when it comes to anatomic location and understanding of the purpose of arteries and veins, then it can become challenging. And what we're trying to do is really simplify that process as much as possible. We're seeing that that technicians are having some difficulty. And so I think once we get a group of technicians and dialysis nurses that are competent enough to use those models, then it will have a downstream effect and potentially be able to be used for the home dialysis patients. But again, I think it's baby steps at this point.
Yeah, another implication, I think, Dr. Chawla from Dallas, also co-fellow of mine, last time talked about endovascular fistula and anatomy. That would be great if they have a model like that they carry around with them when they were in the hospital or got other unit. I think every patient should have a model like this. Dr. Basra, you always have questions, please.
The reason I was just trying to make a comment, there's no doubt that the more anatomically you can visualize and access, the more successful you'll be to cannulate and access. And I've seen disasters like everybody has. But I had a wonderful surgeon named Dr. Webb when I was in Detroit, who would, after he constructed a fistula, would then ultrasound the whole thing, and on the skin of the patient would draw a roadmap where the fistulas were, where the depths were, how deep it was, and say, cannulate here, but don't cannulate here. And then when the patient came, he came with a photograph of his whole arm. So from the very first cannulation, people sort of knew where to go. It worked, not always, obviously, because the sense of touch is so important for a technician or nurse who's doing it. But it's a transition. It would be nice to test a couple of different things, because cannulation many times leads to the premature loss of a vascular access.
Yeah.
Right.
No, and one criticism that we had from the FDA was vascular remodeling. So how valid would this model be for a period of time? And that answer is unknown at this point. I would anticipate that for the first month to 2 months, that there isn't going to be extensive change in diameter of the cephalic vein, for instance. But certainly if there is compromise or thrombosis, and certainly if a surgical revision is required, then there's going to be more limit to what that model can actually do for you.
There's no doubt, and if you have accessory veins develop because of upstream stenosis, and the model changes, so
right?
It does seem like, and Dr. Webb used to redraw the map. He would do it with, and it would, your skin turns over and the map disappears, but the picture stays, and then you draw a new picture.
Yeah.
Well, same was this model. I envision when every technology work out, it become economically more feasible. Probably patient will go every couple months and do another model and bring it to the dialysis clinic. This is really truly patient-centered care. Who want to be stuck multiple times? That's so painful. I think this is a great. Tell me more about this clinical trial. Are you recruiting any of the audience? Maybe if they're thinking about refer patient to you, can they do that?
Yeah, the FDA has really emphasized safety first in this regard, and because we have such limited data at this point, they really want us to start small, meaning to say they want to see results on 10 patients and what those outcomes are. And we've corresponded with them over the last 6 months. This is the most open and collegial communication I've had with the FDA ever, and it was productive. Meaning they after all of that dialogue, they finally did approve the study. But right now, it's safety based. And so we hope to have at least those first 10 patients reported on and communicated to the FDA by the end of 20, and really make use of what this model has for a potential. It's a piece of plastic. It can be put inside of a box and shipped to Hawaii. There's really nowhere that we cannot touch when it comes to being able to receive electronic information that can then be reproduced and sent back to the patient. So again, lots of potential here, but I think we just need to be very careful as to how we proceed, especially when we're dealing with the FDA.
Great. Anybody else have any questions? If I have a patient, if I want to send it to you, I would just give you a call.
Yeah, no. And one last thing, I think this is the most recent, and that is that this IV iron ferumoxytol is now generic. So I believe Sandoz is the one that generates it. So really, I mean, what I envision here is people receiving generic IV iron nanoparticles in dialysis, and then going for their non-contrasted MRA 6 hours later at their leisure, outside of the dialysis unit in an MR facility. We just don't have time to talk about those kinds of characteristics, but this is a blood pool agent. And so we have a lot of flexibility that is really in the purview of the nephrologist and no one else. So again, more to talk about at a later time.
The pediatric radiologists at Lucille Packard Children's Hospital have a good deal of experience using ferumoxytol for these reasons. So we've seen quite a lot of it.
Yeah, unfortunately, there's not as much use on the East Coast. I really appreciate the work that's been done at Duke, and we've kind of mimicked them. But it's great to hear that there's some activity, avid activity on the West Coast.
Great, thank you so much, Andrew.
Thanks again, CJ.
We'll keep in touch, and we are looking forward to continue hearing this.
Wonderful.
We'll bring you back sometimes next year
Awesome.
to talk more. Great. Our next speaker is, thank you. Our next speaker is Dr. Bakrish. Dr. Bakrish does not need introduction. He's well-known. He's a professor in University of Chicago. He's a principal investigator on multiple important clinical trial. And he's going to talk to us about, present a couple cases of managing patient with diabetes. Dr. Bakrish, thank you for coming.
Thank you very much. I appreciate the invitation, and I appreciate being on the West Coast as a Midwesterner. So you've got the whole country covered. I think this is great. So let me do one of the requests that I got is to not only talk about kind of updates in diabetic nephropathy, but also to put into context a newly approved non-steroidal MRA. And what I thought I would do, these are my disclosures, what I thought I would do is go through with you kind of some background very quickly, and then move into really 3 studies and really paint the picture for you, and then finish with a case. So this is where we were in 2001 with the ARBs. You all know this, but I want you to appreciate the amount of residual risk there was in progression of kidney disease for diabetics. So this whole thing is about diabetes. We've got the SGLT2s. We thought they were glucose lowering, and they are so much more. And this is really a nice meta-analysis, if you haven't seen it, in JAMA Cardiology that looks at all facets of SGLT2s. And this is focused on the kidney. So you're looking at patients with atherosclerotic cardiovascular disease on top, and those without atherosclerotic disease, CVD. Doesn't matter. The kidney gets a benefit across the board. And you all know this. And in fact, I was asked in 2019 by the editor of AJKD to write something about GLT2s and why aren't nephrologists using them. And one of the quotes that I put in there is that SGLT2s are cardiorenal risk reducing drugs irrespective of glucose levels. And I think we have enough data now that you would appreciate that statement. So you put the SGLT2s in the equation, residual risk has dropped clearly, but we still have a lot of residual risk. And so when you look at this mechanistically, you've got hemodynamic components covered, you've got metabolic components covered, but there's underlying inflammation and ultimate fibrosis that develops in this disease over time. And the question is, are we affecting this? So we have the non-steroidal MRAs as a way to attack this. Now, this is not your mother's spironolactone. This is a novel class of drugs as defined by the FDA. So let's get an appreciation for this, because one of the things that's not appreciated in diabetes is that the majority of these people, if not all, are obese. And what's also not appreciated is that the fat cells, the visceral adipocytes are highly active endocrine organs. And one of the things they produce is aldosterone. And clearly other immune cells are involved as well. So when you activate the MR system, you can see very clearly a whole host of reactions occur. It's like a nuclear explosion. And this leads to excessive inflammation and tissue injury. Now, this is going on in the presence of ACE inhibitors and SGLT2s, although these drugs clearly reduce inflammation, and this has been shown, they're not going to shut it off. And in fact, to give you just a blow up of where the MRAs are working within the kidney, you can see a whole host of different mechanistic issues. And I'm not going to get into this, but I just want to give you this as background so you can appreciate the effect of MRAs in the kidney and the heart. So let's not leave the heart out of this. This is kind of a cardiorenal axis. So if we then move to the next slide, there we go. We see that there are two distinct classes of MRAs. We have the traditional steroidal agents, which you're all familiar with, and below are the new non-steroidal agents. And the one that's been most successfully studied, and the one that I'm going to talk to you about tonight, is finerenone. So you can see they're very different chemically, and they're also very different in terms of properties. This is a paper that was just published and that looks at the difference between finerenone and the traditional steroidal agents. And you can see a couple of things here that are very different. Number one, there's no CNS penetration. Number two, they're much more highly selective. Number three, the side effect profile is very different and much more benign. No sexual side effects. The half-life is 2 to 3 hours, not Spiro at 3 weeks. And they have no active metabolites. And also, and importantly, they have minimal effects, or finerenone, I should say specifically, has minimal effects on blood pressure. And you'll see some of this as I get into this. Yeah. So when I was approached to be the PI of the study back in 2012, we devised a series, 2 trials, but they would have a similar protocol. And the reason for that is when we finished, we wanted to do an individual patient-based analysis, not a meta-analysis, but really group the patients together because the protocols are similar, the designs are similar, the inclusion criteria are a little different, but you'll see why in a second. And then what does that mean in terms of a really large patient base? So we had the Fidelio program, and for a little cultural point, that was Beethoven's only opera. And we have the Figaro trial, Figaro DKD, and then we have the individual patient-based analysis, which is the Fidelity DKD. Now, all of these are published, and you'll see as I go through this. So using the KDIGO heat map, we have the Fidelio trial, and if you look at what we had originally, the limit here into not going into moderately increased albuminuria is what we had. Now we've extended it into this range, and we've gone a little higher within the albuminuria, the severely increased albuminuria range. And so that's what Fidelio was. And that's what we presented as a late breaker at ASN in 2020. The Figaro trial is a cardiovascular trial with the same protocol, different primary endpoint, and take a look at the heat map as to the people coming in with kidney disease. You can see it's predominantly microalbuminuria or moderately increased, with GFRs in the normal range practically, and extending to an even higher GFR if you had a lot of albuminuria. All diabetes. The way we confirmed it here is everybody got an eye exam. If you did not have evidence of diabetic retinopathy, you did not get in the study. It's as simple as that. So together, combined, that is the fidelity analysis. So I'm going to kind of hit the high points for you. This is the protocol. This is the protocol for Fidelity, and it's for Figaro, and here you see it for Fidelio. And I want to make a couple of points. Unlike any other trial that was done before, we mandated that you come into this trial with maximally tolerated ACE or ARB. So if you came in with 5 of lisinopril, you were out. You needed to be able to tolerate the doses used in the trials that I showed you in the beginning. If you couldn't, you couldn't get in. So that's why we screened almost 14,000 people to get 5,700. This is a diabetes study, the primary outcome you can see there. And the composite cardiovascular endpoint was the primary endpoint of the second trial. This was pre-specified MACE endpoint with hospitalization for heart failure. And then we looked at other endpoints. The GFRs here were 44 coming in. Albuminuria was about 850. And the potassium average coming in was about 4.3. Now, we restricted people that had Ks above 4.8 from coming into the study. So when that screening, if you had a 5 or 4.9, you could not get in. I will tell you at baseline, there was a subset of people that came in that were below 4.8, but they came in, they were at 5. They got in the study. And that's important for what I'm about to show you. This is the primary endpoint, 18% risk reduction. I'll get more into this as we get into it. But kidney failure here was defined as ESKD, and GFR declined to less than 50 mLs per minute. When I said it didn't have a blood pressure effect, you can see what the blood pressure effect was over the trial. On the left part of the screen, there was no change in hemoglobin A1C. And in terms of adverse events, the only adverse event really that was reported was hyperkalemia. Now, this is the change in potassium over the entire study. So you can see that there was an increase, but it wasn't dramatic, 0.23 millimole per liter. And if you look at hyperkalemia leading to discontinuation, you can see it here in the middle part of the screen, 2.3%, 64 people out of 2,827 versus 25 people out of 2,831. Now, that may seem excessive, but remember the GFR is 44, and remember the risk factors for hyperkalemia is a GFR below 45 or a K on diuretics above 4.5, and approximately 3/4 of these people were on diuretics. This is Figaro, and again, same design, except here we had more people and the duration of follow-up was 3.4 years instead of 2.6. Cardiovascular endpoint here, we excluded HFrEF because we didn't want anybody on Spiro because that's the guideline. So HFpEF people did get in, but not HFrEF. And again, the primary endpoint here was a MACE endpoint. And here we looked at 2 levels of GFR. Now, let me tell you why we looked at greater than 40 and greater than 57. When we designed this originally, we all wanted doubling of creatinine as an endpoint, period, end of discussion. We did not know we did not know that hemodynamically in the very beginning, there's actually a drop in GFR with finerenone. It's about half of what you see with SGLT2s, but there is a drop. And we know the FDA, when you're looking at total slopes, if you have an initial drop in GFR, you can't be doing 40% or 50% because there's a lot of issues with it. So you need a doubling of creatinine. So we did it here. And you'll see in the fidelity analysis, we did doubling. So just keep that in mind because you may be surprised. The point I want to make here is this was not a sick group. This is not a group that you would see. This is a group cardiologists would see. The mean GFR was 68. The majority had microalbuminuria. In fact, you can see the breakdown here. In fact, the median UACR was 308. So not normal, but not crazy either. When you look at the primary cardiovascular endpoint, it's clearly significant with a 13% risk reduction, and this was dramatically led by hospitalization for heart failure. Hyperkalemia, dramatically less. 1.2% versus 0.4%. Not a big surprise, better kidney function, so you wouldn't expect a lot. Now, it turns out that in this trial, there was a 36% risk reduction for ESKD. Very dramatic. You wouldn't necessarily expect it, but that's what happened. So one of the take-home messages that the cardiologists now are sending out is that their colleagues need to start measuring albumin creatinine ratios to identify people who are at risk. And as we published back in 2013, microalbuminuria is the kidney's CRP. It's the kidney telling you you've got inflammation, you've got problems. The cardiologist didn't buy into it, but now with this data, there's a lot more buy-in happening. So just keep that in mind. So that brings me to fidelity. In fidelity, we did it the way we wanted to do it. The primary endpoint was the cardiovascular one, the MACE endpoint with heart failure, and then doubling of creatinine was the second one with time to kidney failure, ESKD, etc. So it's merging the data. So 13,171 patients. This is directly from the paper. So the median age in this analysis was 65, mostly males. Pretty much everybody was on a RAS blocker, 72% on statins. The blood pressures you can see here, and 7.7% had previous heart failure. And as I said, that was HFpEF. The distribution of GFRs is here, so you can see that it's pretty equally distributed. And we did have 1% of the people with a GFR below 25. And then the UACR, you can see, was in the 500s. And again, the distribution can be seen there. Well, the primary endpoint was a 14% risk reduction in the MACE endpoint, led almost exclusively by heart failure hospitalization reduction. And the doubling of creatinine was reduced by 23%. Now, when you look at individual endpoints, I just want to show you here, hospitalization for heart failure, significantly reduced by itself, 22% risk reduction. But take a look at the kidney endpoints. You pick one, I don't care. End-stage kidney disease, 20% risk reduction. Doubling of creatinine, I've already told you, that was a 30% risk reduction. So clearly a benefit across the board, regardless of the magnitude of albuminuria that you had. So with that as a background, the bottom line is when you take the totality of the data and put it together in this analysis, you get a 14% CV composite risk reduction, 22% hospitalization for heart failure reduction, 23% kidney composite risk reduction, and dialysis, 20%. Pretty solid data. What happened to hyperkalemia? Well, when you look at the totality of the data, there was more hyperkalemia in the finerenone group, of course, but bottom line is it was a very low discontinuation rate. So the conclusion is that finerenone really should be standard of care on top of ACE inhibitors or ARBs. Now, what about SGLT2s? When we started this study, SGLT2s hadn't even been approved yet. They got approved within the first year of the study. So did we have people on SGLT2s? Yes, we did. 854 people out of the 13,000 were on SGLT2s. Did it matter? This is an analysis we just published in JASN. And what you see here are a couple of things. Number one, you're not going to be surprised if I tell you diuretics reduce the risk of hyperkalemia. Big surprise. But you may be surprised when I tell you that SGLT2s reduce the risk of hyperkalemia. And we published this as well in KI for credence. So the bottom line is SGLT2s are offering a benefit. Now, there's a separate paper, and I don't have time to get into all this tonight. You can ask me questions about it. But SGLT2s did not enhance, wasn't statistically significant further slowing of CKD progression or CV events. But it's certainly, the standard deviation was very large, but it was moving in a more positive direction. I can tell you that. Probably a little more dramatic than GLP-1s, but again, we don't have the data to make that comparison. The point is that there's a lot of information out there regarding this. And so I want you to think conceptually that where we are now is we've got the RAS blockers. We got to think like heart failure cardiologists. We've got pillars of therapy. So we've got the RAS blockers. We all use those. We've got the SGLT2s. Those are on board. And now I think you have to think about adding the nonsteroidal MRAs in people that have established disease at higher risk. So that's the background. Now let's apply that to a patient. 54-year-old Hispanic male. This is a real patient. 54-year-old Hispanic male referred by his PCP for increase in creatinine and a history of diabetes. You can see the past medical history there. I'm not going to go over it with you. The home blood pressures are averaging between 148 and 156, and the heart rates are between 60s and 70s. So that's what you had when the patient came. On physical exam in the office, we found his pressure to be 170/88. And then really, there wasn't much on physical exam. He had some edema, but nothing really dramatic. These were his meds. And so you can see he was already on a fairly reasonable regimen that included a RAS blocker, a CCB, and a diuretic appropriate for his GFR. His albuminuria at the time was 257, and you can see his labs there. His GFR was 52, and his hemoglobin A1C was 7.3. So what we did is we stopped the hydralazine, we increased the bistolic, and by the way, bistolic is nebivolol. And for those of you that know nebivolol and think it's got great nitric oxide activity and vasodilating and everything, you really don't appreciate it until you're 20 milligrams. You got to get to 40 if you really want to see it. So just FYI. We increased the ARB to 80, and we switched to amlodipine, and we started an SGLT2. So that was the change. Patient came back in a month and was basically reporting BPs now in the 140s, well, in the office. And you can see creatinine went up a little bit. His albuminuria dropped to 148. And on the basis of that, and on the basis of the data from the trials, we started finerenone at 10 milligrams per day. Now, arguably in the trial, if your GFR was above 60, you could start at 20, which is the maximal dose. But if it's below 60, we started at 10 and titrated up. So we started at 10. And so now he's on triple therapy. And a month later, he comes back. His K is 4.9. His creatinine's up a little more to 1.85. And his repeat urine albumin is 64 milligrams per day. So it's dropped even more. We then sent him on his way, thought everything was fine, brought him back in 3 months, and now he's reporting home blood pressures in the 130s over 80. And you can see his other lab values, almost normalized albuminuria, creatinine stable, K is 5, on no specific diet, by the way. So with that, I want to just let you know that if you really can maximize the therapy of these patients, you can achieve a lot of good things over time. And this is not happening in routine clinical practice. And the fear factor is there. There's a paper that we just submitted, and it basically compares 2 different trials. And it basically gets at the notion of, is the magnitude of hyperkalemia with finerenone similar to the magnitude of hyperkalemia with spironolactone? And long story short, it's about 2/3 less with finerenone than it is spironolactone. And I can't get into the data with you because it's not accepted yet. It's being reviewed, but that's just one of the things that is out there. I think people need to understand that, at least I'm still hearing, in spite of everything that's been published and stuff coming that I'm aware of, people think this is your mother's Spiro. It's not. So I'm going to stop and answer any questions or comments that you have. Thank you.
Great. Thank you very much, Dr. Barkish. There's a question in the chat. Roy Matthew, it says, why are these patients with high eGFR developing ESRD in 3.6 years? Absolute rate must low.
Well, if you look at the people in the Figaro study that developed ESRD, it was not the people with GFRs in the 60s. There was a subgroup there down that actually came in down to 25, and that's the subgroup that had GFRs that came in at late stage 3B or 4. So that was what was driving that. But the point was that even people with higher GFRs had slowed CKD progression. I think that's the point.
Yeah, I guess the message I get is really we need to start early. When they are in high eGFR, don't wait until they were really advanced CKD. Again, this measuring albuminuria really is quality metrics for every practice, how often you're measuring.
Right.
Now, other question I have is, isn't time for us to learn from our ID specialists, HIV specialists, which they have 3 or 4 antiviral drug into one pill, that it's much convenient for their patient to take, that the adherence will be much better. Obviously, there's some issue with titrating, hyperkalemia, but that could be solved, as you pointed out, with SGLT2 inhibitor plus this, you reduce the risk of hyperkalemia greatly. Obviously, it's different pharmaceutical company, but I think that pathway should be, we learn from our ID specialist.
So let me, you're talking to the guy who in the 1990s was publishing about combination therapy. So this is old news, but I want to just ask you in the audience, how many of you were trained during your residency or fellowship on combination therapy with 2 drugs? Forget about 3. I'm not, that would be insane, but just 2 drugs and using them. They're not on hospital formularies. Nobody's being taught that. And so then all of a sudden you get out and you're like, oh yeah, this looks pretty nice. But then you think it's some gimmick or something. So you're right. But what I've noticed is clinicians, either they're telling me that they're too expensive, which is true, or even if they're generic, a lot of the companies won't pay for them, the insurance companies, and they're afraid to use them. So they're going to use super, super low doses when in fact they've been studied in much higher doses. So it's you you are a product of what you learned in your fellowship. Yes, these CMEs are good, but then you're kind of you have to be intrepid to go in and test these things. So there is the limitation.
Right. Dr. Brian Wan has a question in the chat. Is it recommended to add a low dose diuretic when starting finerenone when initial K is 4.5?
So here's the thing. This patient was on a diuretic. So if they're not on a diuretic, they should be on a diuretic. But keep in mind a couple of things. Little physiology now to this approach. You probably should not start an SGLT2 and finerenone simultaneously. And the reason for that is you're going to get a drop in the GFR with the SGLT2. You're going to get a further drop with finerenone. And so a lot of people may get freaked out because the creatinine is going to go up. And I can give you a whole nother lecture on why you shouldn't be scared of a 30% increase in creatinine, but I'm not going there. It's just you want to do it in a sequential way, but don't forget to do it.
Right. Dr. Yang has a question. Have there been similar study using spironolactone or eplerenone?
First of all, eplerenone has never been studied because it's a crap blood pressure drug. That's number one. Number two, there's the studies that have been done with spironolactone are in heart failure, in HFrEF specifically. And the one study in HFpEF, the top cap, Spiro has never been studied in ESKD in an outcome trial because of the fear of significant hyperkalemia. That's the reason why we're publishing this study with the AMBER trial, which was published in the Lancet, that specifically looked at magnitude of increase in potassium with Spiro in similar patients. So we propensity matched the patients. If you look at that data, it's very clear that Spiro gave you better blood pressure reduction than finerenone, but gave you dramatically much more hyperkalemia in a similar GFR type patients. The GFRs were in the 40s in both groups. So it's different. The binding is different and the translation of the message is different.
Great. There's another question. Marianne Afkarian, sorry if I pronounce your name wrong. What is the diuretic capability of finerenone?
So pharmacology lesson. Number one, spironolactone is a diuretic starting at 50 milligrams. So if you think you're getting diuretic effects at 12.5, you're not. You want a reference? Not a problem. Go to the PDR. This is in the PDR from the FDA. So 50 milligrams is the diuretic dose. The amount of diuresis you're getting at 25 of Spiro is maybe 3.25 of hydrochlorothiazide. Very, very minimal. Finerenone, in terms of diuretic effects, is minimal. You're getting minimal diuretic effects. The paper that I quoted in one of the slides on the British Journal of Pharmacology has all this data. So you can get all that there, but you should not consider it, quote, a diuretic.
Okay, great. Anna Agarwal has a question. How many patients were on potassium-lowering agents in both trials with finerenone?
So the answer is almost none. The start of the trial, we did not mandate anybody use potassium-lowering agents. It was totally up to the investigator. When the study was done in Figaro, I'd say maybe 20 patients, something like that. And that was only for a couple of days. In Figaro, it was more like 70 or 80 patients. But again, it was for 2 days or 1 day until the potassium got organized, and then people got back on.
Great. Any other questions in the audience? Feel free to unmute yourself. Dr. Basarab, you always have questions. There's another question in the chat. 1% of patients with in Fidelia has eGFR less than 25. Was there application on this? A publication on this?
Oh, yeah. There's not a publication on that, but there is going to be a publication on people with GFRs of less than 30. to mimic what I published with the Credence Group in CJASN to look at outcomes. And the long story short, the outcomes in people with GFRs less than 30 were no different than the overall trial outcomes. And in fact, the FDA has said you can start this drug with GFRs at 25 or higher. So that's in the label. So there you go.
Excellent. I actually have two questions. Maybe I missed it. Proteinuria effect with finerenone?
So the proteinuria, okay, so first of all, I didn't show you the data that how did you get 10 and 20 milligrams? We did a study called ARTS-DN. That was published in JAMA in 2015. That was a phase 2 study where we dose titrated just to see what anti-albuminuric effects. The maximum effects were seen at 20 milligrams and at 10 milligrams. So that's why those two doses were picked. 32% albuminuria reduction was seen at month 4, and that was maintained throughout the trial.
Good. My second question is, I'm surprised to see the blood pressure reduction is minimal as compared with spironolactone. I always feel like mineralocorticoid receptor antagonists are really underutilized for blood pressure control. They're really good blood pressure medicine. Back to your comment, it's not spironolactone. Maybe we shouldn't call this a mineral MRA, should be a separate class of the drug.
Well, it is a separate class. That's what I'm telling you. They're non-steroidal MRAs. But listen. This is, I'm gonna give you the analogy now. You're making a statement. You met one brother in the family, and you're making a statement about all the brothers, and you can't do that. And you know that you can't do that. You can't do that with these drugs. There's a head-to-head comparison: eplerenone to spironolactone, 24-hour ABPMs. This is published in Journal of Hypertension back in 2011. Spironolactone destroyed eplerenone. There was something like a 12 millimeter difference between spironolactone and eplerenone in blood pressure. So there's no question, even within the class, there's a difference. If you look at the non-steroidals, if you give finerenone to people with blood pressures of 150, 160, you'll get placebo subtracted about a 5 millimeter reduction. So you do get some. But remember, the people coming into these trials, the blood pressure was like 136. So it's pretty well controlled to begin with. However, within the family of non-steroidals, there is a compound that you may have seen on the slide, KBP 5074. That drug makes spironolactone look low-key. It has an 11 millimeter placebo-subtracted reduction in blood pressure in people with resistant hypertension and GFRs averaging 32. So they're very different, and you can't say, well, okay, they're blocking the same receptor, so the effects should be all the same. ARBs are not all the same. It's a magnitude of binding activity that differentiates ARBs. The reasons for the differences here are not known. They're not known. I mean, I could make something up for you, but they're not known. But they're different.
Great, thank you. Dr. Brian Wan has another question.
Sure.
If SGLT2 use is relatively contraindicated based on eGFR, is finerenone an appropriate add-on to RAS inhibitor?
Well, okay, let me play that back in my mind for you. SGLT2s are appropriate to be used down to GFRs of 20. Finerenone is appropriate to be used down to GFR 25. So I'm not sure where this, so based on that, the short answer is no, because if you can't use SGLT2, by definition, your GFR is below the indication for using finerenone. So no. And this is not, I want you to keep in mind, the concept that reflects the data from the trial. It's not that you had an SGLT2 on board, you had a RAS on board, and then you added finerenone. It didn't work like that. You had finerenone added to the RAS blocker. You may have been in an SGLT2, you may not have been. but the trial reflects RAS blockade with SGLT2. That leap that I move forward in terms of pillars of therapy implies that if you go with the guidelines, you really should be on all three. That's the only point. If you look at the 2022 ADA guidelines, it says you should be on all three. So that's the point that I'm making.
Okay, thank you.
Sure.
Delphin Tool has a question. Would you select spironolactone in heart failure with reduced EF rather than finerenone?
And at this point in time, with the data that is available, the answer is yes, because there's no study that has looked at finerenone. Having said that, there's the fine art study that's looking at this. It's ongoing right now, looking at finerenone in heart failure. That trial will be done in probably 2 to 3 years. And so then I'll probably say, no, you should be using finerenone. And the beauty of that is you'll have less risk for hypotension with finerenone.
Excellent. I have another question. I didn't look at the subgroup analysis between, say, Black versus Caucasian versus Asian in terms of effect. Do you have any outcome data on that?
We have outcome data comparing Asians to everybody else, and we have outcome data on Blacks compared to everybody else. There was no interaction with Blacks or Asians on any outcome that you want, heart, kidney, etc. So there was no difference.
Great. All right, this is fantastic. We can keep talking, and anybody else has any question, just feel free to unmute yourself or type in the chat.
Yeah, I do have a question for Dr. Beckeris.
Yes.
If a patient is stable on spironolactone, this is like we're talking about a couple of years, stable on spironolactone 50 milligrams a day, and then on a ARB also stable, and also SGLT2. So this patient is stable and with creatinine like close to 60. Now, do we consider switching that patient to finerenone? I mean, is there an advantage? Because you did mention something that the GFR might go lower with the finerenone, but with this stable patient, would you consider switching spironolactone to the new medicine?
So there's 2 ways to think about that. If you have a patient that is not having any problems whatsoever, the blood pressure is well controlled, everything is good, and they're on Spiro at a dose of 50 and they're not having any problems, to switch them to finerenone, that's going to be problematic, because the good news is finerenone has an indication that Spiro doesn't have. So you want to follow, the trials, you would do that. On the other hand, those indications are for people that are not stable. They're not on other therapies. You're building the therapies. So switching one out for the other, you're going to lose blood pressure control if you go to finerenone. If this person needed blood pressure control, if he doesn't need blood pressure control, then yes, I would switch, because down the road, as he loses kidney function, which he will, you're going to have more problems with potassium with Spiro earlier than you will with finerenone. So those are the things you have to consider. So I would have to think about that before I made any changes.
All right, thank you.
Sure.
Great, thank you. There's another great question in the chat from Dr. Kawadi. Can you comment on the role of finerenone on non-diabetic proteinuria kidney disease?
Well, I could be like the former President Nixon. I'm glad you asked me that question. That probably, this group's way too young for that. Okay, I would say basically that you'll have to wait about 2 years, maybe 3. There is a trial going on right now that I'm part of in non-diabetic kidney disease, looking at finerenone's effect, not just on albuminuria, but looking at finerenone's effect on outcomes. Just like DAPA-CKD looked at the subgroup of non-diabetics, that's what this is. So the short answer is yes, I think it does have an effect. Otherwise, why is it being looked at? Is it going to be across the board? I don't think so. But then again, we're not looking at polycystic kidney disease. So I think, you know, I cannot tell you why there's such a dramatic effect of SGLT2s in IgA nephropathy. I don't have a clue. And yet there it is. So I think we're going to find out, but I would have to say yes.
All right. Thank you so much, Dr. Bakrish. There's another question. What is the cost difference of spironolactone, eplerenone, and
among the
finerenone?
three agents, it must be huge at this point in time.
Anatole, my friend, no. It's $10 a month if you have the card
If
for
you have the card.
finerenone, and spironolactone is about $10 a month, at least in Chicago. So no. Now, if you go in cold, you know, walking in off the street and then you don't know what's going on, yes, you can have sticker shock, as you can imagine. So there are issues with that, and they need to work on the pricing. Let me put it this way. They need to work on it. But
Okay.
right now you can go 1 year with a coupon card, $10.
Well, I'll wait till a year from now because I've noticed at times that
Well,
prices
things may
go up.
change by then. Things may change. There's an evolution going on.
Yep,
but
yep, yep.
There's no need to wait a year from now. You can get that discount now. It's not going to be a year from now. It's ongoing right now.
Is it? Okay.
Yeah.
Well, we always have our friend Randy to help us on this if there's a cost issue, right?
There you go.
Great. This is really exciting time for us with so many new development and so many new medication for our patients. Really appreciate, thank you for all you do, Dr. Bakrish, and really grateful you come to join us and teach us. With that note, our next speaker is Dr. Glenn Chattal. And again, he does not need any introduction. And he's a professor at Stanford. And all I can say, he's a wonderful, wonderful friend. He's always so kind to teach us. And I would probably say he's the mentor for everyone. Dr. Chattal, thank you.
Thank you, CJ. Let me think about sharing my screen, but before I figure out how to do that, since I'll be ending the evening meeting, I'll try not to keep you here until 8 o'clock. But I have to say just kudos. First of all, thanks to Bayer for sponsoring the night and for helping bring some outside speakers in. I'm a local guy. I just think it's tremendous recruitment by the NKF and by you, CJ. We have a fantastic contingent of colleagues from UC Davis. Way to go. A great group of people here from Kaiser. I think I saw Neha Arora on the participant list. I just have to shout out to Neha that it's been a number of years, but we miss you every single day at Stanford. Kaiser is so damn lucky, so damn lucky to have you. And I also have to remind you that today is actually Thank Your Mentor Day. This is true. And, although both Drs. Bakrish and Dr. Bessarab, were barely out of fellowship by the time I finished my training, I consider them both to have been major and important mentors in my career as I began to think about doing clinical trials, and I look toward both of them for their guidance, and I just thank both of you for being mentors for many years. So, and this is true, it is Thank Your Mentor Day. I got an email from the American College of Physicians today. And thank you, Patty. And it's just so terrific to see friendly faces and people I haven't seen. I wish we were meeting in person. There's Masi Safai. I haven't seen you in ages. David Menke, lots of wonderful people. I miss seeing you. So I'm going to have the opportunity to speak.
Dr. Chattel, before you move on,
Yes.
can I make a request for the audience if you can turn on your videos so we can all see each other? Obviously, it's totally voluntary. Go ahead.
So thank you, CJ. So I'm going to have a chance to speak with you a little bit about anemia and some novel treatments that I've had the privilege of working with. First, a couple of disclosures. I've served as co-chair of the vadadustat phase 3 trials programs. Listed here, the Innovate program in patients receiving dialysis and the Protect program in patients not receiving dialysis. I show here for your interest in reading, if you haven't seen them, the primary reports from those 2 trials. I have also served on the steering committees of the DAPA-CKD trial and the Prioritize HF trials, and as chair of the Stabilize CKD trial with AstraZeneca. And you may know AstraZeneca has co-developed roxadustat with FibroGen. So I've not been involved in the roxadustat program, but I have worked with AstraZeneca as George had mentioned with the DAPA-CKD trial. I have no financial interest in these entities, and most importantly, I continue to serve as president of the CJ Zhang fan club. So sorry about that. Some background on anemia. None of this is going to be news to you. And just a word on words. You'll see in some of these slides, it's hard to decide how to describe CKD and anemia. Anemia, is it due to CKD? Is it associated with CKD? Is it caused by CKD? I think it's very difficult to be sure. I have generally moved toward using the term CKD-related anemia because there are undoubtedly patients who have CKD and anemia who have myelodysplasia, but it just hasn't been diagnosed yet. So this is a slide from a recent slide from the general population looking at patients with and without CKD and by CKD stage. And you can see, of course, that the prevalence of anemia increases dramatically with more advanced CKD and is seen in more than half of patients with advanced CKD, that is stage 4 and 5, with anemia being defined as a hemoglobin below 12 for women or below 13 for men. So it's a very common manifestation associated with CKD or related to CKD, maybe due to CKD. The pathophysiology of CKD-related anemia is multifactorial. We, of course, know there's decreased red blood cell production. There is a reduction in iron absorption that's been well delineated now related to a heightened response in hepcidin, elevated hepcidin associated with the inflammation, particularly in advanced CKD, and diminished iron absorption. We also know that there's reduced red blood cell survival, particularly in advanced CKD with uremia. Now, chronic inflammation is an important component. We know that this is multi-organ involvement, and it involves the kidney, liver, the leukocytes, and iron absorption. Hepcidin regulates iron absorption and availability, and we know that there is a very high frequency of both absolute and functional iron deficiency in patients with chronic kidney disease. And Dr. Bessarab has done some really seminal work in the area of anemia and CKD. He really should be giving this lecture rather than I. Now, this slide is a nice cartoon, and I like it. And it shows how many areas of health anemia can affect or can be related to, but not necessarily in a causal manner. So we know that anemia is associated with CKD progression. It's associated with cardiovascular disease, mortality, hospitalization, reduced health-related quality of life, and other clinical manifestations. Whether it's actually caused by anemia or by confounding factors that contribute both to CKD and anemia is unknown. Had we had available perfect medications with no adverse effects that could correct anemia without any risk and without any perturbation of the usual homeostatic mechanisms, then we might be able to determine whether anemia causes these factors. But I just think that the agents we have used and that we continue to use are imperfect. And so we can correct anemia very effectively. But it's not clear to me that we can correct anemia with existing medications and at the same time correct the associated increase in adverse health events, including hospitalization, heart failure, stroke, mortality, by correcting anemia. And this has been a real dilemma for investigators since Anatoly worked on the normal hematocrit trial now more than 20 years ago. We do know that the things that really matter to our patients are associated with anemia, including things like CKD progression and cardiovascular disease. On the left panel, you can see the rates of cardiovascular disease with and without anemia, and the rates of CKD progression with and without anemia. So patients with earlier stage CKD who have anemia progress faster than patients who don't have anemia. 18 months versus 28 months. Is the anemia responsible for that progression? I don't think so. But there are factors associated with both, whether this is inflammation or other factors. I'm not certain. But it certainly correlates with these factors that really matter to patients. And you can see things like physical activity and fatigue, which are also associated with anemia. And some of these can be corrected, though the degree to which they're corrected within the range of hemoglobins that we now focus on are not clear. To think that when I was in training and early in my career, we were transfusing people with cardiovascular disease to bring their hemoglobin over 10 is just astonishing to me. Really, with no hard evidence that that was a beneficial practice. And the levels of hemoglobin we were targeting many years ago, because it made sense that patients who had higher hemoglobin concentrations and the observational data suggested better quality of life at higher hemoglobin. It did not necessarily translate into better health by correcting hemoglobin from low levels to higher levels. So we have been on this search for means by which we can correct anemia in a way that can capture some of the associated decrements in health that are evident from observational data. And we simply haven't gotten there with clinical interventions that we've tested. Again, here we see mortality and hospitalization. These are dramatic differences in terms of mortality rates. in patients with and without anemia and CKD, and hospitalization rates double the hospitalization rate. But when we correct anemia, do we reduce the hospitalization rate? We were never able to show that with ESAs. So there was always the hope that we would be able to do so with other agents that might do other things other than, we know that the ESAs, with ESAs, we can correct anemia very well. I always felt that, and would tell our fellows, this is not the major, correcting anemia isn't the major unmet need. It's correcting anemia and abolishing the observed hazards associated with anemia, and we haven't been able to do that. Hence the excitement about a new class of agents. So what do the clinical practice guidelines tell us? Well, they do suggest that we should be thinking carefully about iron supplementation, and there's a strong rationale for iron therapy. And the evidence in support of iron therapy goes beyond the nephrology literature. I suggest that the cardiovascular literature is at least as strong as ours with respect to correcting iron deficiency. Iron can raise hemoglobin concentrations with or without ESAs. And my practice, I don't know if Neha recalls when we worked together, but I used to just tell my colleagues, just wave a vial of Epoetin alpha in front of a patient with CKD, and you'll see the hemoglobin will come up. Wasn't always the case, but it did happen periodically. And I would always reach for iron, at least intravenous iron, with which we had considerable experience and which has been a strong mainstay of therapy. And I think many of us have overestimated the hazards associated with intravenous iron. There have been a number of studies that have tried really hard to demonstrate an increased risk of infection or increased risk of hospitalization or mortality associated with iron administration, and we simply haven't been able to demonstrate it. The link between iron and infection that we think about so often, and the nurses from the dialysis unit call me about so often, is really linked to a small cadre of gram-negative rods, predominantly Yersinia species. Now, I don't even remember the last time I saw a patient in the hospital with a Yersinia infection. We see patients in the dialysis unit with staph and strep and enterococcal infections, occasionally E. coli, Klebsiella. There's really no evidence that iron supplementation places those patients at risk, yet we're very fearful of the use of intravenous iron. I just remind people the second bullet under considerations for iron therapy. We published a couple of papers now 4 or 5 years ago looking at the use of ferric citrate coordination complex, which is also now an Akebia product, or Auryxia. And the results for patients with CKD who have laboratory manifestations consistent with iron deficiency with the administration of ferric citrate are really quite impressive, and quite a bit more impressive, in my view, than what we see with conventional oral iron formulations. So if you have a patient with sparse vascular access or a patient on peritoneal dialysis in whom you don't want to do repeated administrations of intravenous iron, this is a very attractive option. I wouldn't consider it a novel option at this point, but it's an effective option that I think remains underused. So with respect to the use of ESAs, the KDIGO guidelines recommend the use of ESAs to treat CKD-related anemia but much more cautiously than we did 10 or 15 or 20 years ago, where we really are using ESAs only when we've addressed correctable causes, only when we've really tried hard, and I sometimes don't think we try hard enough to rule out reversible or non-CKD related causes of anemia, GI bleeding, iron deficiency, others, hematologic abnormalities, and to really balance the potential benefits versus the risks of therapy. Red blood cell transfusion carries considerable risk, but that risk varies quite a bit depending on the patient characteristics. Now, if we have patients who are unsensitized and really wonderful young patients awaiting kidney transplantation, I do everything in my power to avoid transfusion and sensitization that can ultimately make acquisition of a deceased donor kidney, or a living donor kidney for that matter, much more challenging. Whereas for a healthy patient without heart failure, who is 75 years old, and say has a history of one of the cancers with which ESA use has been associated with more rapid progression, a blood transfusion in someone who is not going to be concerned about sensitization for transplant may not be an horrendous intervention where we really try to avoid transfusion in potential transplant recipients. But the use of ESAs were developed to basically prevent the use of blood transfusions. I am old enough to remember my years as a third and fourth year medical student rotating on 6D, which was the renal unit at Brigham and Women's Hospital, where I was a third year clerk. And the renal unit basically was the largest consumer of packed red blood cells in the hospital. And the patients, I think ESAs have gotten very, very deeply criticized for their adverse effects, but anyone who was around before the time that ESAs were available can remember how the patients felt. Jeff Young, you were in practice before then. I'm sure you can comment on how patients felt before and after the introduction of ESAs in clinical practice. Just a tremendous burden of illness with chronic anemia and chronic transfusion requirements for patients before ESAs were initially approved in 1989. But we're trying to strike a balance between correcting anemia and some of the adverse effects that we're concerned with, some of which may be overestimated, some not. So the guidelines, and I think most of our practice is we should really only be giving red blood cell transfusions when the benefit outweighs the risk. And when someone, for instance, is having acute hemorrhage, I think we need to be very careful about overcorrecting anemia, particularly when the anemia has been slow to develop and chronic. I've seen quite a few older patients develop severe heart failure symptoms with 2 units of packed red blood cells given in a routine manner, and giving them slowly or splitting units or giving 1 unit at a time is often a much safer means of administration. And there are certainly patients for whom ESA therapy is either ineffective or less effective than we'd hope. Of course, the bloodborne infection issue is not what it was 20 or 15 or 10 years ago. Immunological reactions still occur. I think volume overload and hyperkalemia are the main problems that we still have to deal with in our patient population, patients with advanced CKD or ESRD who need transfusions. So where are the unmet needs? And I hinted at the fact that it's really not, I mean, there are people who have ESA resistance, no doubt, but it's really correcting anemia without adverse effects. So just to give a general sense of how widely practice varies in across the world, you can see the average epoetin alpha dose in different countries across the world, with Japan at the lowest end, US at the highest end. These are patients. You can see the farthest most on the left panel, the farthest most US asterisk is for patients who've been on dialysis for longer than 180 days, so longer than 6 months. So clearly, they're the patients who have maybe either who are receiving transfusions early in their course or who have residual kidney function and don't need quite as much ESA are different. But you can see that we are outpacing other countries in Europe and Asia with higher doses of EPO. And you can see that in the rightwardmost panel, there is a wide variation in the use of IV iron, where the US is on the lower side of average, but you see a number of the European countries that are more avid users of iron than even we are. And Japan, there's very little use of intravenous iron. And why the Japanese can have such a different pattern of iron utilization and EPO dose requirements is not entirely clear to me. Maybe Anatoly, I don't know if you have any comments about that, but this has been, years and years of just phenomenal results where the Japanese dialysis population maintains higher hemoglobin concentrations without the use of intravenous iron and with much lower doses of ESAs.
Glenn, it's not specific to Japan. It's actually the Far East. If you really look at data coming from China, Japan, Korea, Singapore, in other words, that whole belt seems to be able to tolerate ferritins of less than 200 and TSATs but they have TSATs of 30%. There's something different about the way they handle. And so they don't have to use a lot of iron because they have good TSATs, so they can deliver the iron, not need as much erythropoietin. But the reason for that's not clear. No one has really studied the genetics. Is it the diet that they have? They do fortify with iron, for instance, in Japan. So there's oral iron coming in whether you need it or not in your diet. So I don't know, but it's an interesting question.
Well, if you don't know, no one knows.
Maybe they're less inflamed.
Their CRPs in their population are roughly half of what they are in the US. So if the average is about look at the studies that have been done and you look at the Japanese versus the Western European USA studies, and this is select populations.
And no catheters.
And no catheters, right? No catheters allowed. In the Japanese studies reported out of Japan, the CRP median was like 0.1 or 1.7 per liter. In the US, it was more like 3.8. So there is a shift to the right, and no persons with inflammation were really enrolled. Very few people with values of 10 or 15 per liter. So, the studies are little, but I think there's something different about the metabolizer in their diet or something, but no one has bothered to study it, actually, that I know of.
It's a fascinating
It's
difference.
fascinating, yeah.
Maybe there's a lot of iron in the sushi they eat.
It's possible.
Uni, it's all in the uni. So I
There's
won't
a couple
go through
questions in
this.
the chat, but let's wait until Dr.
Yeah.
Chattel finish.
So, I won't go in through this ESA timeline. You're familiar with most of it. The practice patterns change so enormously over these decades, just enormously different. And in 2011, the world changed not only with the FDA modification of dosing recommendations, but with bundling. So I also won't go over these now very well studied and well understood trials, the normal hematocrit study, the QUIRE and TREAT studies. Of course, the TREAT study was the purest in that it was a placebo-controlled trial as opposed to a target trial, and no difference in the primary composite endpoint, which is often lost in terms of the general concern about harm, but a doubling of stroke risk, which was a real concern for this population. Again, these were patients with non-dialysis requiring CKD, who had all of whom had type 2 diabetes. So a few words about the hypoxia-inducible factor pathway. Just some cartoons about how the body manages normoxia and hypoxia. And in the setting of hypoxia, the renal erythropoietin producing cells upregulate their production of EPO, and we see increases in iron utilization. And in CKD, where this doesn't work, so this is the repeat on the left panel, a repeat of the right panel from the last slide, what you would expect in the setting of hypoxia in healthy kidney function, the increased production of EPO and the increased utilization of iron. Both of these are impaired in CKD because of reduced erythropoietin production and diminished iron utilization, trapping, lower absorption, etc. So there are adaptive mechanisms from this hypoxia-inducible factor pathway, which activates these adaptive mechanisms. These are proteins considered to be the master controllers of the response. And just remember the terms, they're called hypoxia-inducible factor, prolyl hydroxylase inhibitor. And the reason that they are called that is because the alpha subunit of the HIF is regulated by the prolyl hydroxylase enzymes, why they're called HIF PHIs, or the prolyl hydroxylase inhibitors. So in normal oxygen condition, these enzymes degrade the alpha subunit of the HIF, and the dimer doesn't form and the pathway is restricted. But it can be activated in the setting of low oxygen, or in the setting of blocking of those prolyl hydroxylase enzymes, which is the science that went into the development of the HIF-PHI class of drugs. So this is a means by which we can mimic the effects of hypoxia, high altitude, and some beautiful work many of you may remember from Wolfgang Winkelmeyer, who spent 5 or 6 years on our faculty, along with Alan Burkhart at University of North Carolina, showed just beautiful associations between altitude and mortality in patients on dialysis, where patients who lived at higher altitudes experienced lower mortality rates. And this tells us that having higher hemoglobins are not the problem, but maybe having higher hemoglobins through a mechanism by which we provide pharmacologic erythropoietin dosing or analogs of erythropoietin may not be the right answer. Hence the enthusiasm of this class of drugs. Could we develop prolyl hydroxyl inhibitors that could allow the HIF dimer to remain activated, mimicking the effects of higher altitude, helping to better utilize iron, increase endogenous EPO production, and increase hemoglobin without experiencing the adverse effects associated with the ESAs, or the conventional ESAs. And this is really just a summary of what we've gone over. Just the HIF pathway is a therapeutic target and an exciting one, and we've seen the last year and a half data coming out that I think it tempers some of our enthusiasm, but I still think there is power in this pathway. And just like with ESAs, I think we can eventually learn how to use these agents judiciously and improve the lives of our patients as we have with ESAs. I wish that some of the younger nephrologists had had the chance to see patients before ESAs were available, because they dramatically changed the face of kidney disease care. But they're not perfect. And apparently neither are the HIF PHIs. So I'll end with a couple of slides on timeline. You can see the vadadustat, roxadustat, and daprodustat, all three of which have been in development in the US for some time. Roxadustat was first out of the gate and had its first submission to NDA, their first NDA to the FDA. They had an advisory committee meeting in July and did not receive approval from FDA and are back to the drawing board. The program with which I've been involved also submitted an NDA last year and have a date from FDA scheduled in March. That just means they will say something. It doesn't mean they will approve or not approve, but they'll say something. Hard to imagine that they wouldn't ask for an advisory board after an advisory board was requested for roxadustat, but who knows. And daprodustat presented data at Kidney Week 2021. Many of you probably saw that and published two parallel papers, as did we, in the New England Journal of Medicine, describing those results. Just to give a general sense, and I won't read through this slide, but just a general sense of the clinical profile. Roxadustat is a very potent drug with very dramatic and very strong efficacy results. But there were some safety concerns which were raised by the advisory committee and by scientists at the FDA. But quite impressive efficacy, maybe a dosing issue. We know that there are hazards associated with excess dosing of ESAs as well, and maybe lower doses of roxadustat could be used very safely. We just don't know where this will be headed. Vadadustat did not as potent results in terms of efficacy. Very clean results with respect to comparing cardiovascular and non-cardiovascular events relative to darbepoetin, so an active control as opposed to a placebo control. with results looking quite good in the dialysis population, but there were findings associated with the administration of the drug in patients who were not on dialysis, where the risk of what was defined as MACE, but isn't really MACE, it's non-fatal MI, non-fatal stroke, and all-cause mortality as opposed to cardiovascular mortality. But MACE and MACE plus in the non-dialysis requiring patients favored darbepoetin over vadadustat. And the daprodustat trials did meet their non-inferiority margins, but there were also some adverse effects, and we haven't seen the results of any regulatory evaluation. This is the third agent out of the gate. So we have 3 agents, an exciting pathway that was the science behind this pathway of HIF stabilization. Won the Nobel Prize in Medicine in 2019. It's elegant, it's exciting, it mimics high altitude. There was every reason to think that it would be favorable and might not have some of the adverse effects seen with ESAs, but alas, another set of imperfect agents. So with that, I will end and take questions for anyone who's willing to stick around for another couple minutes.
Great, thank you so much. Anna has a question. The difference in iron ESA utilization in Japan contributory to getting approval of daprodustat in Japan?
I know that roxadustat and vadadustat are approved in Japan, and I know roxadustat is approved in China. I'm not sure about vadadustat. I'm just not sure about the regulatory status outside of the US.
If I can just add, actually, 3 of the agents are approved in multiple countries. And roxadustat is approved in the EU at this point. The problem with the US studies was that I could spend an hour saying how not to design a clinical trial, even though I had some input that wasn't listened to. But the fact of the matter is, I think in Japan, they did very short studies. They're really more interested in efficacy, and they look at safety once the drug is out in the market. And there's a commitment. All the companies have to do very large post-marketing studies to really define the adverse event trials. And that's also true in China. That's the way China does it. So the model is very different from the FDA, who wants you to do a 2-year study with 6,000 patients. There, the sample size is smaller. And I don't think it has anything to do with the iron metabolism or the way iron is handled by these ethnic groups differently. I think it's a question of how they view clinical research and what is needed. Regulatory and evaluation comes downstream, as far as I can understand, in many of these countries.
Okay, Roy Matthew has a question. Could the HIF inhibitors be the inflammation-induced EPO hyperresponse patients?
Well, I think there clearly is a subpopulation, however you define it, a subpopulation of patients with ESA resistance. There are undoubtedly going to be differential responses to different drugs that act via different mechanisms. And some of this is also clinical trial, practice. So for instance, in the roxadustat studies, my understanding is that the starting dose of roxadustat was selected in part based on the existing dose of ESAs for the patients who were previously treated with ESAs. Whereas in the vadadustat trials, everyone in the trial was started on a fixed dose, irrespective of their prior ESA dose. I'm not sure which approach is better or smarter, or they're different approaches.
I think, Glenn, you're correct. I've never understood the rationale for having two dosing regimens based on the pre-existing ESA dose. Doesn't make any sense because there's so much variation over time.
Right.
If you look at someone over a year, their dose is very different at different quarters of the year. So it made no sense to me, but those are decisions that other people made. So I don't know what the right is.
All right,
And
go ahead.
one other comment. I've always believed that there is too much hurry in correcting anemia. I did grow up when we transfused people. I became an attending in 1975. So let me tell you, that was way before EPO. And the change with ESAs in the late 80s when they came out was remarkable in the patients, just remarkable. We don't have patients like that anymore. Most of our patients don't get started until their hemoglobins are 9 or below 9. So you don't have to go as far. So what's the rush? Take 3, 4, 5 months to correct the hemoglobin slowly. We noticed back in the early introduction of ESAs that we had thrombosis of our axes when we went from hemoglobins of 7 to 10. And even more so when we went to hemoglobins of 13. So there's a problem of viscosity, some interaction of platelets, other factors, which modulate our ability to target a hemoglobin. It's never going to be normal. I ideally think 11 is perfect for most patients.
Great, thank you. Another question, what is the clinical space / niche for HIF inhibitor? And there are patients with higher than normal endogenous EPO and hemoglobin 16 to 18 range who are incredibly exercise tolerance and none of adverse effect ESA induced target hemoglobin, even normal range. Is the reason HIF inhibitor or unique to individual HIFs?
Yeah, so I'll take that one. That's a complicated question from my friend Miriam. I think that tells us that there are people with polycystic kidney disease or other conditions who have normal hemoglobin concentrations. Those patients are not intrinsically at higher risk, but pushing them to higher values from lower values does seem to increase the risk, and it's just a different circumstance. As far as the clinical space and niche for these drugs, they're oral agents, which is much more convenient for people who either have non-dialysis requiring chronic kidney disease, and they don't have the convenience of 3 times a week access to their circulation, no injection, just squirt something in the bloodlines. The advantage to patients from a convenience standpoint in the dialysis units is, it's basically none. I would say that, unfortunately, some of the data in non-dialysis requiring chronic kidney disease doesn't look as good as we had hoped. And there's another comment in the chat about, could this be because some patients don't get offered dialysis? And that is an interesting observation and an interesting thought. And we've presented data from the PROTECT, from the vadadustat trials that looks at that. But that would require that there's an imbalance in patients who require dialysis. That's why we do randomized trials. So there would have to be more people if if one drug looks worse than the other, and it's because, you know, they're in a poor country and they don't have access to dialysis, there would have to be some imbalance in patients with more advanced CKD who are more likely to develop kidney failure and then more likely to find themselves without access to dialysis services. You would hope that there wouldn't be an imbalance in randomization. Unfortunately, in the vadadustat trial in PROTECT, we did have an imbalance in the estimated GFR in certain regions of the world where patients randomized to vadadustat had lower eGFRs and were more likely to have eGFRs at the start of the study below 15 or below 10. And people were entered into these trials because it was the only way that they could get treatment for their anemia. And then they got treated for their anemia, but then didn't get dialyzed. And that also is a, you know, as Anatoly said earlier, you know, that's a big boo-boo when it comes to designing clinical trials. You know, that's a lesson learned from, you know, you can't control, you know, even large numbers. You can't necessarily control within a country or within a region whether there's balanced randomization for all factors that really matter.
Yeah.
So you better not conduct a trial in a region where you can't get people dialyzed if they need to be dialyzed. And that may be the, you know, that may be an explanation for why some of the findings were as they were for vadadustat trial. I'm not certain.
And that happened in one of the trials that had a lot of Central European patients in the FibroGen study too. We noticed that some people were started with GFRs of 7.
Yeah.
But didn't necessarily wind up on dialysis or follow-up. So it is a real problem when you go to poor countries.
Yes.
Because the
yes.
motivation is for the patient. It's not for the study.
Yes.
Great. Anna has a question. Do you think that worse cardiovascular outcomes that was seen in vadadustat are going to be particular to HIF inhibitor or unique to individual HIFs?
You know, they're all different molecules. They act in the through the same pathway, but they're clearly different molecules. Roxadustat has a favorable effect on the lipid profile. Vadadustat has no effect on the lipid profile. Roxadustat had some adverse effects, seizures, infection that were not seen in the vadadustat trials. So they're different drugs, and I think I don't know that George Bakris is still on, but you know he described he described these vast differences in effects of the mineralocorticoid receptor antagonists and the ARBs. You know, we often, I think, erroneously make the assumption that all drugs of the class are the same, and they're not.
Right. Great.
I think if you were to
we are
study, and just one comment, I think if you studied all the various drugs, if you can turn on 300 genes, they don't do all 300 genes, that will have different patterns. And that's why we shouldn't think of them as a class. We really shouldn't, you know, as all members of the same class. There are going to be differences.
Great. Thank you. We are 13 minutes over. Can I have a last question? As we know, in the COVID era, we are very cautious with ESA on COVID patient with anemia. Has any study looking into possible role of HIF stabilizer in COVID patients?
Well,
I'm not aware of any.
and besides, if you had the degree of inflammation that you will see in a COVID patient, we don't even know how effective these drugs are. They seem to be better in quote unquote hyper-responsive patients, but I don't think the kind of inflammation that you see in COVID or in pancreatitis or any very severe, you're going to be able to treat with any of these drugs. I mean, without transfusions.
Great. Thank you so much. What a wonderful night. Learn a lot. And Patty, you want to finish up?
Thank you, and please fill out the evaluation. And thank you so much, Glenn, and our other speakers. It's lovely to see your faces and your names and know that you're out there. And may 2022 bring us together, IRL, as the young people say in real life.
So
Ciao. Good night.
thank you so much. And
Good
CJ,
night.
thank you for your continued leadership.
Oh, thank you. Thank you for joining us. And Dr. Basra, we need to invite you to give a talk next time.
Well, somewhere along the line, I can follow some threads, yes. Remember, I have
Somewhere
two
along
loves
the
in
line,
my
yeah.
life, two loves in my life, anemia and vascular access. Either one of
All
us.
right. Vascular access.
Take care.
Take care.
Bye-bye.
Dr. Minky, good to see you.
Thank you, Bayer.
Thank you.
Bye-bye.
Bye-bye.
Bye.
Thank you.
I had a quick question. Don't these new drugs work by raising the erythropoietin level? And has the levels been measured?
I
We
think,
lost Glenn. I'm not sure there's anyone here that can.
right. Probably not that I know of, but don't take my word for it. Good to see you, Dr. Minky. We missed you.
Thank you.
Bye.
Bye,
Thanks for
everybody.
joining us, Dr. Namer. How are you?
Thanks, Rani, for helping sponsor this.
Thank you, Dr. Zhang. I'm so glad you gave us this opportunity to be here today, but I will reach out to you tomorrow on LinkedIn. We'll chat.
Great.
Take care.
Great.
Bye.
Bye.
Stop recording.
I will now.